Good afternoon, friends and respected Sharda ma'am. Topic for today's talk is evolving role of IV FCM in pregnancy. Let us start with what is the global burden of anemia worldwide. Barring Australia and the United States, seems as if every nook and corner of the world is afflicted by anemia. And coming to our own country, the level of public health significance is severe. And as per the National Family Health Survey 5, 2019-2021, it was found, the key findings were that overall 57% women aged 50 to 49 years were anemic. In pregnancy, the incidence was 52.2%. In men, relatively less, 25%. Adolescent girls were almost to the tune of 60%, and in children from 6 to 59 months was 67%. This shows how bad the situation in our country is. This data indicates a significant increase in anemia prevalence among women and children compared to the previous survey, sparking concern and underscoring the need for enhanced efforts under the Anemia Mukt Bharat program. So just a basic revision of anemia in pregnancy. What are the various causes? We know, start with the nutritional deficiency, then abnormal hemoglobin synthesis, hemolysis, which could be because of G6PD deficiency or sickle cell anemias, because of defective iron absorption and metabolism. It could be also because of blood loss, because of antepartum hemorrhage or worm infestations. Certain chronic conditions like tuberculosis or rheumatoid arthritis or HIV would also lead to anemia. Let's come to the iron requirement. The daily average requirement in the first trimester is 0.8 milligrams, and it increases to 7.5 milligrams in the third trimester. There was this myth about the Western diet being better than the Indian diet because they had non-vegetarian food. But this was an eye-opener that the daily average absorption from a Western diet is 1 to 5 milligrams, and an Indian diet is at par 0.8 to 4.5 milligrams per day. So we have no reason for being behind the Americas and Australians. What are the consequences and why we are so much focused on prevention of iron deficiency anemia? Because of the increased fetal and maternal morbidity as well as mortality. 18% of perinatal mortality is because of maternal anemia and 20% of maternal mortality, which so sad is in our country. The complications can be anything from a preterm delivery to PPROM to preeclampsia, IUD infections, hemorrhages. Fetal outcome, we know low birth weight, prematurity, premature delivery and its consequences. So how do you diagnose iron deficiency anemia? Is just hemoglobin enough? Is just a peripheral smear or a complete hemogram indicating hyperchromia and microcytosis enough? Do we need to do a serum ferritin levels, a cutoff of 30 to diagnose iron deficiency anemia? Well, as per the WHO and many national guidelines, it should be done in the first trimester so that we have an idea of the baseline iron stores. Then there are several other indications where you do go for a serum ferritin. If the hemoglobin is less than 11 or we take the cutoff as 12 and there is suspicion of anemia, to differentiate iron deficiency anemia from other causes. Number 3 is when the patient is very compliant, she is taking iron tablets, but she is not responding. So then again to check if the anemia is due to iron deficiency or some other etiology. Then there are certain high-risk groups who are at risk or prone for iron deficiency anemia. Those with a short pregnancy interval of just a year, teenage pregnancies, multiple pregnancies, poor dietary intake, malabsorption syndrome, or women with heavy pre-pregnancy menstrual losses who were already anemic and have conceived. If there is a history of significant blood loss, like with the bleeding hemorrhoids or GI bleeding for any other cause, and also before you start parenteral iron therapy, to confirm the deficiency and to determine the iron requirements accurately. Also, once you've given her the parenteral iron, and again to monitor the replenishments of iron stores, whether she needs a further assessment or further IV iron, or we can switch over to oral therapy. So what is the oral iron supplementation? One tablet of, say, like we take iron ascorbate has 100 milligrams. So as per the Foxy GCPR 2017, in established mild to moderate anemia and the pregnancy is less than 32 weeks, and those who respond very well to trial of oral iron, in those situations, so please keep in mind mild to moderate anemia, pregnancy gestation less, so that she is in her second trimester and she is responding well to oral iron, then you continue giving her 100 milligram elemental iron That is one tablet to be given twice a day along with 500 micrograms of folic acid. And once he's achieved the requisite hemoglobin levels, then a prophylactic daily supplementation with either 60 or 100, or you can go back to one tablet for at least 6 months during pregnancy, and then postpartum also should be continued for 6 months because she is then be lactating. So that is the Anemia Mukt Bharat program that we recommend. 100 milligram twice a day, and otherwise once the level is achieved, we switch over to prophylactic, which is 60 to 100 milligrams. Now, what are the shortfalls of oral iron? By dosing her many times a day, we may be giving her the dose more than the RDA, and it may be because of less efficient absorption. Excess of enteral iron levels will affect her GI system, and then starts the nausea and the diarrhea and the constipation and pain in the abdomen, which will reduce her compliance. And excess of unabsorbed iron, like you just mentioned, Dr. Ela, also shown to have a negative impact on the composition of the gut microbiome. So this is what happens. She doesn't tolerate oral, then you have to switch over to IV iron. So what are the various parenteral iron compositions available in our country? We have iron dextran, iron sucrose, ferric carboxymaltose, and iron isomaltoside. What are the properties of an ideal parenteral iron? Coming to the type, it should be robust. The molecular weight should be more than 100 kilodaltons. Complex stability should be high. Half-life should be long. pH should be neutral. Osmolality should be isotonic. Antigenicity low. Test dose should not be needed. And the time for injection should be short. And the maximum doses should be that we can give her the maximum possible doses so that the repeat injections are not needed. Coming to ferric carboxymaltose. This is a type 1 or a robust parenteral iron. It is not associated with dextran-induced hypersensitivity. It can be administered in much higher doses. We know that there is 500, 750 milligrams and then 1 gram also, 1000 milligrams. And a short infusion time. We have to write down in our prescriptions that it has to be administered within such and such time. You need to underline it because despite your repeated instructions, the sister in the casualty or in the ward will still give her in 1 hour's time, and that is where the complications will start. So go on emphasizing. I tell my patient and her husband that you look at the watch when they start the infusion and insist that it should be over within 15 minutes. Iron is released slowly, so it avoids toxicity and oxidative stress. The structure is similar to ferritin, so it is easily deposited in the RE system. So there is no increase in the unwanted iron levels. A test dose is not required. Again, I think all of us have observed repeat writing, instructing, they will still give her IV iron and make a permanent black mark on her arm. And it has low immunogenic potential. So everything should be written in capital. Tell the patient and her family ki aise aise hoga, and send the patient to a place where you know there are all facilities. It should be in the morning time. Where the doctors on duty, the junior doctors are all available. और घर पे नहीं लगेगा, casualty में होगा where everything is available. Yes. So let us look at the clinical evidence for FCM in pregnancy. So comparison of ferric carboxymaltose and iron sucrose complex for treatment of iron deficiency anemia and pregnancy RCTs. 100 pregnant patients diagnosed with moderate to severe iron deficiency anemia were taken in this study, and intervention was 50 of them were given FCM, 1000 milligrams in 200 ml of normal saline, and the other rest 50 were given isomaltoside, 300 ml in 200 ml of normal saline. The parameter, the end result was rise in hemoglobin from baseline after 12 weeks. And what was the conclusion? It was significantly higher in the FCM group than in the isomaltoside group. So there was a rapid replenishment of iron stores with significantly higher HB rise after a 12-week period. Also, convenient dosing with lesser number of total dose to complete the treatment, leading to better compliance. Another research article where ferric carboxymaltose in the management of IDA in pregnancy. So here again it was found that the baseline levels were higher with FCM. So in the management of iron deficiency anemia, rapidly corrected the anemia in a short period of 4 weeks with favorable safety in the second and the third trimester of pregnancy with all severities of iron deficiency anemia, irrespective severe, moderate or mild. So it is been approved for use in daily clinical practice. There's another study where again they were, after 2 weeks the study reports were assessed and there was a significant rise in HB as well as the serum ferritin levels. So a very quick response. Another research article, now this is where when the hemoglobin levels fall down, what do? Do you switch over to twice a day oral iron, or would you like to go in for a single intravenous oral, single IV iron, or you would recommend twice a day? So the study objective was, if a single dose IV iron for primary treatment of moderate maternal iron deficiency anemia in the second trimester, whether it is superior to twice a day oral iron in reducing the incidence of low birth weight infants and also the incidence of maternal anemia at delivery, wherein the hemoglobin cutoff was taken as more than 11 grams at 30 to 34 weeks or at delivery. And what was the primary outcome? So we are looking at two outcomes over here. We are looking at the birth weight of the baby, which was assessed after 72 hours of delivery, and we are also looking at the attainment of a non-anemic state, that is hemoglobin more than 11 at delivery. So why are we talking about two primary outcomes? Because iron deficiency impacts both maternal and infant outcomes. So two primary outcomes were selected. And what was the key result? It was found that with oral iron, the incidence of low birth weight babies were 29%. With IV ferric carboxymaltose, the incidence was 25%. So compared to oral, there was a significant reduction, but comparing to the IV ferric dairy isomaltose, then it was almost the same. So in short, with IV iron preparations, the incidence of low birth weight babies also reduces compared to oral iron. Then there was another study that achieving the non-anemic state without needing additional IV iron or blood transfusions. With oral iron, the incidence was 54%, and with IV preparations, it was 68%, meaning you have given her oral iron twice a day, yet you have not been able to achieve 11 grams or 12 grams as we take it. You had to supplement her with additional IV iron despite oral iron twice a day. You still had to give her either IV iron or you had to give her a blood transfusion. So that in case of oral iron studies was found to be yes. The conclusion: first line treatment of moderate maternal iron deficiency anemia with single dose infusion of IV ferric carboxymaltose results in reduced rate of low birth weight in infants compared to standard of care oral iron without increased safety concerns. With all treatment arms achieved similar rates of non-anemic state by delivery, both IV iron arms had improved response for treatment and reduced rates of blood transfusion or need for any additional interventions compared to oral iron. Have I made it clear? Yes. So what are the implications? Clinical guidelines should consider the potential benefits of single dose IV iron, particularly ferric carboxymaltose, as a primary treatment option for moderate iron deficiency anemia in pregnancy, especially in settings with high rates of low birth weight. The improved attainment of non-anemic state without rescue treatment suggests a more effective and potentially less burdensome approach for the patients. Obviously, one shot and you don't have to then worry about repeat or a blood transfusion. So what are the FOXY GCPR 2017 recommendations? Parenteral iron can be an alternative in mild to moderate anemic pregnant women who are non-compliant or intolerant to oral iron. Parenteral iron is also recommended for pregnant women with severe anemia who are hemodynamically stable and they require rapid restoration of iron stores in the second and early third trimester of pregnancy. Meaning, if she is not about to deliver, you still have time to give her IV iron in pregnant women with severe anemia. So, coming to the main point, are all FCM the same? So, this was a research article wherein they compared the physiochemical analysis of the various ferric carboxymaltose preparations in India. So there are 8 competing FCM formulations. Now the regulatory bodies like EMA, FDA and IP, they emphasize the importance of assessing the key physiochemical properties such as the particle size, the molecular weight, iron content, osmolality, density, iron core composition, pH levels, because these factors will affect the bioavailability, the safety and therapeutic efficacy. And this study evaluates the physiochemical properties across various FCM brands to determine their influence on the effectiveness, the compatibility, and of course safety profile. And what was the conclusion? FCM is, so besides pregnant women with iron deficiency anemia, it is also used to manage patients with CKD, where we know that anemia is there and there. Also those with cardiac diseases, with cancer, and during pregnancy, allowing for rapid iron restoration with fewer doses and economic benefits. Research on injectable FCM in India reveals significant quality and safety differences, aiding healthcare professionals in selecting the effective treatments. So brand A demonstrates strong physiochemical properties compared to the innovative brand and outperforms many other FCM products, making it a reliable choice for IV iron supplementation with ensured therapeutic efficacy and patient safety. So what are the key takeaways? Maternal anemia contributes to 18% of perinatal mortality and 20% of maternal mortality. FCM is a type 1 robust parenteral iron not associated with dextran-induced hypersensitivity, can be administered in much higher doses in a very short infusion time, which is 15 minutes. And clinical guidelines should consider the potential benefit of single dose IV iron as a primary treatment option for moderate iron deficiency in pregnancy, especially in those settings where the incidence of low birth weight babies is very high. Research on injectable FCM in India reveals significant quality and safety differences, aiding healthcare professionals in selecting effective treatments, and Orofer FCM outperforms many other FCM products.